Move on to third presentation by Dr. Srushti Raj. He will be presenting role of shunts in glaucoma management, ab interno and ab externo.
My thanks to the organizers for providing me the opportunity to present my talk here. So it's a long topic, so I'll be discussing a broad view of the ab interno as well as ab externo devices. So there's no conflict of interest to declare. So what is the role of glaucoma drainage devices in current glaucoma management protocol? So we have two type of stents, ab externo and ab interno. Initially, it was used for failed trap or for inflammatory glaucomas, but now more and more, even primary surgeries can be done with stents as well as combined with cataract surgery. So, trabeculectomy or tube. We know that trabeculectomy is still the gold standard for lowering the pressure, and prerequisite for this is healthy conjunctiva. And use of shunts is increasing since last 20 years. So when the surgery is indicated, when the risks are outweighed by the potential benefits, when target IOP is not achieved, or there is a progressive glaucoma damage based on the disc findings and fields. So these are the some of the stents used: Molteno, Krupin, Barbal, EGV, Adi. These are the external stents. And for internal stents, there are different mechanisms like suprachoroidal drainage outflow, Cypras, which is band, eye stent, supra, and eye star. Then subconjunctival blood forming like Zen and pressure flow. Then trabecular outflow increasing like eye stent, hydrus, GAT, KDB or canaloplasty, and some of the end stage procedure like DLCP or ECP. So glaucoma drainage devices indications are basically the failed trabeculectomy, inflammatory glaucomas, or if there is any significant barrier to the use of medications regularly, or if it is inconvenient to the patient due to physical impairment or psychosocial issues, or if there is a rapid progression despite the best medical management. Why shunt? What is the problem with trap? So there are a lot of early and late post-operative complications associated with trap, like infections or choroidals or shallow AC and complications of shallow AC. So indications of drainage devices, there are wide range of indications like failed trap, aphakia, pseudophakia, PAS, then post-trauma scar, post-PPV or uveitic glaucoma or neovascular glaucoma. So when to do shunt surgery, there should be appropriate decision to operate. Pre-operative consideration is very important, especially for inflammatory glaucomas like uveitis, where you have to put the patient on anti-inflammatory therapy 1 to 3 days prior to the surgery to get the better result. And per-operative consideration like minimal handling of the UVR iris tissue and friable conjunctiva and sclera. So minimal use of tooth forceps. Also the post-operatively, the follow-up is vital, especially the inflammatory glaucoma. So the aggressive anti-inflammatory therapy is required. So GDD can be valve or non-valve. These are two types of GDD available, and material-wise, mostly these are silicone or polypropylene based. Ab externo, which we are using are mostly AGV or the here. The others are available. So ab interno available are express, shunt, Zen, eye stents, omni, pressure flow, hydrus. Most of these are not used here. These are some of the designs of these devices. So success rate of drainage devices varies from 70 to 79%, and maximum is seen with Moltena DP device. Complications. Hypertensive phase is usually seen with the valve devices. With AGB, it is seen almost in 40 to 80% of the patient. And use of MMC with shunt is usually not indicated. There is increased chances of hypertonia, flat AC, and choroidal fusions with use of MMC. And complications like persistent hypertony, vitreous hemorrhage, choroidal detachment, shallow AC, bleb encapsulation. Other complications, though transient hypertony is seen in 12 to 26% of the cases, but usually it is transient. And diplopia is more seen with barbell type of devices up to the tune of 9%. This was a Fuchs heterochromic cyclitis patient who underwent cataract with glaucoma surgery, who was on maximum medication, and post-operatively he had a good control with one drug. This was the post-PPV patient, PPV patient with 34 pressure on maximum treatment, and after GDD came to 14 with one drug, and vision was also well maintained. This was the infantile glaucoma patient who already had OPK with high pressures on maximum treatment. After AGV, the pressure was 14 with one drug. Most of these GDD devices will require one or two drugs in post-op period. So AGV or ADI. So this was a study published by our group where we compared the ADI versus AGV, and the inference was that both are equally effective, though less medications are required with ADI. This study was the long-term outcome of AGV implantation in post-PPV eyes, and the conclusion was that IOP is well controlled with AGV in these cases also, but trauma-related pathologies were a major contributor to the indications for PPV in this group, and had more chances of failure following AGV implantation. This was our retrospective studies comparing ADI versus AGV, and outcome was both are equally effective, but considering the cost factor, ADI was well placed. This TVT study shows that equal pressure lowering effect on short-term basis, and 5 years result shows that 49% failure with trab and 30% with tube, and 5 years result shows that early complications were more with tube and late complications were almost equal, and late complications like resurgery and cataract section were similar in both the cases. This Cochrane analysis shows that there is insufficient evidence show that whether trab is better or the drainage devices are better. So TM based mixed procedures which we usually perform are trabectomy, GAT, KDB, bang. Eye stents are usually costly, so usually not done here. Recently we have done bang in some patient standalone also, and in combination with cataract surgery also, and usually we get the lowering of the pressure around 20%, and also there is a decrease in number of drugs. This is so in conclusion, GDD success rate is similar to GFS, but indicated in failed trab or inflammatory conditions where there is a lot of conjunctival scarring. Preoperative consideration, especially in inflammatory glaucomas, should be considered, and careful patient selection, preferred valve GD devices in one eye patient, and ab interno procedure mostly favored in mild and moderate glaucoma. Thank you.
Thank you, Dr. Shirish Raj. Any comments from panelists?
I think as Sir has mentioned, as of now, the current standard approach for most of the glaucoma surgeons is to do trabeculectomy in cases, uncomplicated cases, and reserve the valves, either ADI or the AGV, for patients for glaucoma cases which have a slightly lesser response. For example, the uveitic glaucoma, the neovascular glaucoma, or failed trabs. And the MIGS procedures are coming up in a big way. So patients who have early to moderate glaucoma, where we want to delay the trab for a few months or few years, then we can think of the ab internal procedures like GAT or other eye stents or bang, those sort of implants.
Also, the number of drugs will come down, and
Yes.
that is equally
The ocular surface will be
medications
better.
not-
Yes, the long-term success of trab will be better.
Thank you.
Thank you. Thank you so much, sir.